Very good morning, everyone. I, Dr. Rahul Agarwal. Today, we will be discussing about the drugs for the peptic ulcer. So, I will be covering the topic under the various subheadings. Uh, First, we will see the physiology of the gastric acid secretion, how the gastric acid is secreted, and what will be the target, where we can target the drugs. Then, classification of drugs, various drugs which are used for the acid peptic disease. So, we'll see that. And then the drugs for the H. pylori. H. pylori is Helicobacter pylori. It is a bacteria which is responsible for causing the peptic ulcer disease, and many cases, recurrent cases arises because of this H. pylori only. Then we will see the regimen, various regimen which are for the H. pylori cases. Various regimen are there which are for the H. pylori cases. We will see that. Then some of the review questions in the form of MCQs that you have to answer, and that will give you more insight. That is why some review questions will be there. So, coming to our topic, peptic ulcer. Peptic ulcer generally means the breach in the mucosa. Whenever there is a breach in the mucosa, then mucosa when it is breached, then ulcer will occur. So that is the peptic ulcer. So peptic ulcer, the breach can be in the gastric part, then it is known as the gastric ulcer, and then it can be in the duodenal part also. So peptic ulcer has two components: gastric ulcer and the duodenal ulcer. So in the gastric ulcer, acid secretion is normal or low, but the normal defense mechanism which was there, which protect, normally the acid don't cause any damage to the stomach, to the mucosa of the epithelium of the stomach. But if there is a deficient mucosal defense is there. If there is deficient of that mucosal defense, then gastric ulcer will occur. तो duodenal ulcer में क्या होता है? Acid secretion high होता है. This acid goes into the duodenum and will cause the breach in the epithelium of the duodenum. So that is why the duodenal ulcer. So gastric ulcer and duodenal ulcer, these are the two parts of the peptic ulcer. This is very important to understand that we have two types of factor. One is the aggressive factor and one is the defensive factor. The balance should be maintained between the aggressive factor and the defensive factor. To become healthy, to remain healthy, the balance should be maintained. Aggressive factor in the form of like H. pylori, Helicobacter pylori, it's a bacteria. It is responsible for causing the peptic ulcer disease. Non-steroidal anti-inflammatory drugs. Suppose you are taking the lot of non-steroidal anti-inflammatory drugs like paracetamol or aceclofenac or diclofenac. There is a chances कि ज्यादा लेने पे गैस्ट्रिक एसिडिटी बढ़ जाती है. एसिड, पेप्सिन, स्मोकिंग, जो स्मोक करते हैं उनको भी एसिडिटी ज्यादा होती है. So aggressive and defensive factor in the form of mucus bicarbonate, like mucus is there which protects the epithelium from the damage by the this gastric acid. Bicarbonate, blood flow, healthy blood flow is when there is a healthy blood flow, then less damage will occur. Prostaglandins are there, which is again form the mucous layer. So we'll see that also. So if there is a balance between these two, then the person will remain healthy. But if there is more aggressive factor and there will less defensive factor, then it will this will go towards ulcer gastritis. So it will cause the gastritis. So normally the gastric acid and pepsin, they do not produce damage because we have the intrinsic defense mechanism. Normally also there is a gastric acid, there is acid in the stomach, but that don't damage your stomach because you have the defense mechanism in that. That is the intrinsic defense mechanism. So what we can do, if there is any patient who is having the acid peptic disease, what we can do to him, that we can decrease the production of acid. One target can be done. और जो acid बन चुका है, we can utilize that also. So when we have the target to neutralize the gastric acid by antacids. So we have the antacids, and I think you know the antacids, name of antacid, very common antacid, digene. So we have the antacids which neutralize the gastric acid. You have the drugs which decrease the secretion of acid in the stomach. There are a lot of drugs which decrease the secretion of acid in the stomach. We'll see that. You have the drugs which increase the protective factors protective factors like mucus and bicarbonate, and what I was telling about you, the prostaglandins. Prostaglandins are responsible for the secretion of mucus and bicarbonate. You have the drug which protect the ulcer by forming a layer over it. So suppose there is an ulcer and one layer is over that ulcer. So what will it will do? Now the acid will don't touch the ulcer. Because of this layer, acid will don't touch that ulcer, and the ulcer will heal with some time. Stimulation of the healing of ulcer, so we can promote the healing of the ulcer. So these are the strategies which are used to treat the acid peptic disease. Okay, and finally we can treat the H. pylori if there is a H. helicobacter pylori which is responsible for relapse, and so that's why. So we have the drug which can kill the H. pylori also. Okay. So this is the diagram of the physiology of the acid secretion, how the acid is secreted uh, in the stomach. So you know that acid is secreted in the stomach with the through parietal cells which are present in the stomach that secretes the acid. This is important. This you have to remember. This is the parietal cell. Now this parietal cell is having, you can see the three receptors. Just to focus on this one. It's having the three receptors. M3. M3 is the cholinergic. We have discussed that also. H2 is histaminic receptor. Histaminic receptors having different subtype H1, H2, H3, H4, H5, and CCKB. CCKB is cholecystokinin B. So these three receptors, when it gets stimulated, it will stimulate the parietal cells, and when the parietal cells is stimulated, this stimulate this proton pump, and proton pump is, what is proton? Proton is H plus ion. Okay. When there is a pump, when there is energy required, then it is proton pump. The proton pump is also known as H plus K plus ATPase pump. Because of this activation, H plus ion move outward into the lumen, and this H plus ion will combine with the Cl minus ion to form the HCl. So that is how the acid is synthesized. So we can target here M3, we can target H2, we can give the blocker of this, we can give the blocker of this, we can give the blocker of the proton pump. Among all these, which will be the more effective? Can you tell me? Among M3, H2, CCKB blocker, and among proton pump inhibitors, which one will is the more effective? Obviously, proton pump inhibitors, because all the M3 and H2 and CCKB, they are acting through proton pump only. When you are directly inhibiting the proton pump, then it will be more effective. So PPIs like prazoles, omeprazole, pantoprazole, rabeprazole, they are also they are very commonly used drugs. You have heard about that these drugs are very commonly used. You have heard the name also because they are used very commonly. That is why you have heard the names. Okay. This is again the diagram showing the glands, various glands of the stomach. So see the parietal cells, the structure of the parietal cells. The parietal cells are responsible for synthesizing of the acid, H plus ion. Okay. So normally, I was telling about you ki normally the acid in the stomach do not damage the esophagus. Why? Because there is a presence of gastroesophageal junction. There is a sphincter is present which protects the uh, protect the acid from going from stomach to the esophagus. So that is why they don't damage the esophagus. How come the acid is there in the stomach, then also it is not damaging the stomach? Because of the presence of protective factor, and that is the mucus layer. The mucus layer, because of the presence of mucus layer, the stomach or the gastric epithelium do not get damaged. You can see by this diagram, prostaglandins EP3 stimulate the EP3, and that is secreting the mucus layer. And this mucus layer is protective. But how the acid is secreting from the stomach, it is going into the duodenum also. Why the duodenum is not damaged? Again, the duodenum is not damaged because of the secretion of bicarbonate. Again, prostaglandins are normally present. They stimulate this, and bicarbonate are synthesized. This is the misoprostol. We have the drug which stimulate the prostaglandins again, and that is again will be helping in secretion of mucus and bicarbonate ion. Okay, that is the gastric mucosal defense. We have seen that mucosal defense, protective factors. Now coming to the classification. So what we have the target, you can target the you can reduce the gastric acid secretion. How you can reduce the gastric acid secretion? I told you these three part, we can give the H2 blockers, histamine, H2 blocker. H1, remember H1 for the allergy, H2 here for the gastric acid secretion. So H2 blocker, all the drugs ending with the tidine, cimetidine, ranitidine, famotidine, roxatidine. These are the H2 blocker which reduces the gastric acid secretion. The second is the PPIs, proton pump inhibitors. You have the prazoles, omeprazole, lansoprazole, pantoprazole, rabeprazole. So all the PPIs, they also reduce the gastric acid secretion. Clear? Okay. Third is the anticholinergic. Anticholinergic because you are targeting here on M3 receptors. You are targeting here on the M3 receptor. That is why the anticholinergic. So it blocks the, if this is blocked, again the this proton pump will not get activated. Parazepine, anticholinergics. Then the prostaglandin analogs, we have seen prostaglandin analogs that was responsible for uh, mucus and bicarbonate secretion. The protective factors, misoprostol and prostal. So this is for the reduction of gastric acid secretion. Now, second thing you can do the neutralization of gastric acid, antacids also. You can neutralize the already formed gastric acid. तो जो gastric acid बन चुका है उसको हम neutralize कर सकते हैं. तो कैसे neutralize करते हैं? Systemic sodium bicarbonate and sodium citrate. But systemic is not very commonly used because it has itself having the adverse effect, and non-systemic magnesium hydroxide, aluminum hydroxide. We'll see to it. Then you have the ulcer protective. जो ulcer बन चुका है उसको protect करना है. कैसे protect करना है? By forming a layer over that ulcer. So sucralfate and colloidal bismuth substrate, they form a layer over that ulcer. Ulcer healing drug, carbendazole on sodium. And finally, anti-H. pylori drug, we have the antibiotics which can kill the Helicobacter pylori bacteria, clarithromycin, metronidazole, amoxicillin, various H. pylori drugs. So we will see today in this topic only. So coming to the H2 antagonist, they block the H2 receptor in the parietal cell. We have seen the mechanism, all ending with the tidine, ranitidine, famotidine, cimetidine, loxone. And in fact, the H2 antagonist was the first drug for the among the acid peptic disease. For the peptic ulcer, the first drug was the H2 antagonist only. And then in that too, cimetidine was first approved, but this H2 antagonist is not a very good drug when we compare with the proton pump inhibitors. So now the proton pump inhibitors are the drug of choice. But the important part of H2 antagonist is it suppress the basal nocturnal acid secretion almost completely. So that is why here it is important for the basal acid nocturnal रात के time जो acid का secretion है, for that the H2 antagonist is very good drug. Okay, cimetidine was the first drug which was introduced into the market, and that was the first H2 blockers. It is generally well tolerated with adverse effect less than 5%, but this cimetidine is not used nowadays because of this major drawback of it is inhibiting the cytochrome P450. As it is inhibiting the CYP450, it will have the lot of drug-drug interactions, so not very routinely used. Then came the ranitidine. This ranitidine is used, no doubt. Ranitidine is used. It mechanism of action is same, inhibit the acid production by reversibly competing this H2 receptor on the basolateral membrane of the parietal cells. Okay, next, ranitidine is having the good pharmacokinetic profile, rapidly absorbed after oral administration. It has available both orally and intravenously. You have heard the name of Rentec, I think. Rentec is the ranitidine only, orally and intravenously. Half-life ranges from 1 to 3.5 hours. Very less protein bound, so free form of the drug is more, so it will be much more effective. And one thing you have to make it clear that it is excreted by the kidney. So any patient who is having the renal dysfunction, that in that dose has to be adjusted for that. Okay. Adverse effect is not very much adverse effect, generally well tolerated with less adverse effect. IV form can cause confusion, delirium. Thrombocytopenia can rarely be seen and can cross the placenta also. So ranitidine is avoided in pregnancy. Ranitidine not to be given in pregnancy. If there is if in pregnancy there is a increase in the acid secretion, then prefer the PPIs. Ranitidine not to be given. Ranitidine, both form is available. You can see the tablet form, Rentec, and the injectable form for the emergency use, for the IV use, Rentec is used. Why ranitidine is much more better than cimetidine? There are various advantages of ranitidine over cimetidine. First is the long duration of action. Once a day dosing is sufficient, long duration of action, and ranitidine is having the less adverse effect profile. Anti-androgenic action, main anti-androgenic action, which was having with the cimetidine, is not there with the ranitidine. So that's why it does not cause the increase in prolactin and gynecomastia. So no anti-androgenic action, do not cross the blood-brain barrier, so less CNS effect and less drug interaction as it does not inhibit the CYP. So it is not do not in, it is do not it is not inhibiting the cytochrome P450 enzyme, so less drug interaction, so can be used safely. It is potency wise also, ranitidine is much better than cimetidine. So this is the desirable features of why ranitidine is used over cimetidine. This is an important question, can be asked in the university exam. So this is important question. Incidence of side effect is lower with the ranitidine. One more drug has came into the market, famotidine, which is orally available. It is more potent than ranitidine. Again, it is less adverse effect profile, no anti-androgenic action, long duration of action, and adverse effect is also low. So this is also a good drug, famotidine, but it is only available orally. Any anywhere where the acid secretion is more than that, in that case, H2 blockers can be used. It can be used in the peptic ulcer disease, non-ulcer dyspepsia, bleeding from stress ulcer, and erosive gastritis. For gastroesophageal reflux disease, there is a reflux causing into the esophagus. Prophylaxis of aspiration pneumonia, again because of the gastroesophageal urticaria. Why urticaria? H1 receptors are responsible for the allergic reactions, allergies, and here H2 blockers you are given. So many times the drug blocks the some H1 receptor also. So that's why urticaria, it can be used in urticaria, but not very commonly used in urticaria. This is important drug. This is the important group of drug because very commonly this proton pump inhibitors PPIs are used, and proton pump is also known as H plus K plus ATPase. This you have to remember. H plus K plus ATPase. प्रोटॉन प्रोटॉन का मतलब होता है H प्लस और ATP लगता है H प्लस K प्लस ATPase. H प्लस K प्लस का एक्सचेंज होता है, दैट्स व्हाई H प्लस K प्लस ATPase. So developed after H2 blockers, but it is the most potent drug, inhibit both the basal and the meal stimulated output, and all the drugs ending with the prazoles are here, the proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, lansoprazole, omeprazole. So all the drugs ending with the prazoles. Some pharmacokinetic profile, if we see, it's a weak basis. So it get damaged with the gastric acid. So proton pump inhibitors are not like that. You give the drug and it going to the stomach and it is inhibiting directly in the proton pump in the stomach. It's not like that. You give the drug, it is crossing the stomach, then it going to the intestine, it enters into the blood circulation from the intestine, and from the blood circulation it is acting on the parietal cells. So the thing is like this. So you have to give the drug. You should give the drug like proton pump. If you don't give with the covering, अगर covering के साथ नहीं दोगे proton pump को, तो acid उसको destroy कर देगा. So these drugs are weak bases हैं, इसीलिए protect करने के लिए उसको antric coated tablet दिया जाता है, ताकि वो acid से destroy ना हो पाए. Acid से destroy नहीं होगी, तो it goes into the small intestine, it absorbs from there, and then it reaches its circulation. From circulation, it comes into the parietal cell. Got it? Should be given before the first meal. Why before first meal? Because the proton pump which you are targeting, they are the maximum activity. They have the maximum activity before the meal only. So PPIs are the prodrug, and they get activated. All the PPIs are the prodrug. They get activated in sulfinamide. And very important point, the PPIs are the hit and run drug, because once the proton pump get inhibited, it is remain inhibited until unless the new pump is synthesized. Okay, like you hit with the car and run away. So this is like this only. कि it hit करता है proton pump को, and it run away और चला body से disappear हो जाएगा. Then also the proton pump remain inhibited, क्योंकि नया proton pump आएगा तभी वो काम करेगा. Clear? So it is a classical example of hit and run drug. Can you give me another example of hit and run drug? Yes, very good. Aspirin. Aspirin is also a classical example of hit and run drug. It irreversibly inhibit the COX enzyme. Okay, very good. One interaction is very important with the proton pump inhibitors and clopidogrel. This is very important because clopidogrel is a antiplatelet drug. You give to if to decrease the clotting of the platelet. So antiplatelet drugs you give in MI and stroke. So clopidogrel is a prodrug. It gets activated by the help of enzyme CYP2C19. You can remember with the CYP, CYP2C19, 1919 is looking like, see this clopid L is looking like 1. So CYP2C19, clopidogrel get activated with the help of enzyme, this metabolizing enzyme CYP2C19, and this active metabolite is responsible for its antiplatelet activity action. But if you are giving concomitantly proton pump inhibitors, what is proton pump inhibitor is doing? It is inhibiting the CYP2C19. Now, what happened? When it is get inhibited, no active metabolite, no antiplatelet action. Now, the clopidogrel action will not come. If this will not come, then definitely the patient can land up into the emergency, like with the diagnosis of MI or stroke, because you have given the clopidogrel, but then also it is not acting. Okay, so this interaction was very important. PPI with clopidogrel, very commonly this is asked in your questions. So remember this interaction, PPI and clopidogrel. What will be the adverse effect of PPI? PPIs are generally very safe drug. When it is used for the very long time, then only the adverse effect is generally seen. Otherwise, adverse effect is not seen with the PPI. Uh, and how adverse effect is seen? Like you are giving the PPI, it is decreasing the acid, then vitamin B12 level is reduced because of the vitamin B12 required the acidic medium for the absorption. So subnormal vitamin B12 level. Increased risk of hip fracture again because of reduced in the calcium absorption, and increased risk of enteric bacterial infection, and when pneumonia risk is also increased when long term, means 4 to 5 years when PPIs are given, then these adverse effects are generally seen. Otherwise, the PPIs are very safe drugs. Uses of PPIs. Again, the PPIs are used for all the disease which are having the high acidity, like peptic ulcer, bleeding peptic ulcer, stress ulcer, erosive gastritis, GERD, aspiration pneumonia, Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is severe form of gastric hyperacidity. So this is now the second part is the third group of drug. First we have seen what we have seen. We have seen the H2 antihistaminics. Then second we have seen the PPIs. Now the third we are seeing the anticholinergic drugs. Anticholinergics are not non-selective, decreases the gastric acidity and also delays. They like the cholinergic M3 receptors, selective M1 blockers. M1 receptors are there, and you have the M1 blockers like paranzapine and telenzapine, but they are not very much effective. So not very much used. So, but paranzapine and telenzapine, you have to remember, it selectively blocks the M1 receptors and are preferred for peptic ulcer. Acid suppressing agents like PPIs, H2 blockers can result in tolerance and rebound hyperacidity also due to secondary hypergastrinemia. Okay. Now we have another target which can increase the mucosal defense. How we can increase the mucosal defense? By increasing the prostaglandins. And prostaglandins inhibit the gastrin production, also increase the mucosal blood flow. Like you have seen this misoprostol, prostaglandin analogs, stimulating EP3, then again it is causing the secretion of mucus and bicarb, and this is the protective mechanism, cytoprotective action. It is having the short half-life. The prostaglandins analogs have the short half-life, but prostaglandins analogs have itself having the adverse effect, lot of adverse effect, but it will be the most specific for the NSAID-induced peptic ulcer. Why? The non-steroidal anti-inflammatory drugs, what is the mechanism of non-steroidal anti-inflammatory? It is inhibiting the COX enzyme. When the COX enzymes get inhibited, it inhibits the production of prostaglandins. Now you have the drug which increase the production of prostaglandins, the misoprostol. So that's why misoprostol is most specific for NSAID-induced peptic ulcer. But there is a side effect of prostaglandins analogs, so that's why not very commonly used. Side effects in the form of diarrhea, abdominal pain, increased GI motility, abdominal cramps. Sometimes abortion also occurs with the uterine bleeding. So that's why very safe drug misoprostol. Okay. Now coming to the antacid, one antacid which you very commonly know is the Digene. Yes, very good. So antacid, we have the systemic antacid and the local antacid. These decreases the acid which is already produced. They do not decrease the acid production. Antacid do not decrease the acid production. Please remember, antacids only reduces, neutralizes the acid which is already produced. Do not decrease the acid production. Neutralize the acid for up to 2 hours. Antacid combine with the acid and produce the salt and water. This is how they neutralize. It combine with the acid and produces salt and water. Antacid, if you give the liquid preparation, like you have the Digene, liquid preparation also and tablet also. So liquid preparation better neutralizes the acid than the tablet. Like this diagram, you can see the antacid, liquid preparation, Digene, magnesium hydroxide and aluminum hydroxide. One important adverse effect with the magnesium hydroxide, this you have to remember. Ki magnesium, remember with the mnemonic MD. Magnesium causes diarrhea, and aluminum hydroxide, aluminum causes constipation. So don't get confused. MD, remember the MD, MD, so, Master of Medicines, MD, magnesium causes the diarrhea, aluminum causes the constipation. Another group of agent, the ulcer protective. What it is doing? It is protecting the ulcer. As the name is, it is protecting the ulcer. तो अल्सर के ऊपर एक लेयर बना दे हम ताकि अल्सर उसको अल्सर प्रोटेक्ट करे. तो सुक्राल्फेट जो है, सुक्राल्फेट बेसिक एल्यूमिनियम सॉल्ट ऑफ सुक्राल्फेट, सल्फेटेड सुक्रोज है. सुक्राल्फेट पॉलीमराइज होता है, बाद में पॉलीमराइज हो जाता है एट पीएच लेस देन 4. पॉलीमराइज होके जो इकट्ठा हो जाता है एंड इट फॉर्म्स द ओवर द अल्सर के ऊपर एक लेयर बना लेता है. तो एसिड, that acid don't touch with that ulcer, so adheres to the ulcer base, should not be given with the antacid. Why? Because the reason is here, sucralfate polymerizes at pH less than 4. sucralfate के molecules जो बहुत सारे मॉलिक्यूल्स जब जुड़ते हैं वो पॉलीमराइज होते हैं, वो एसिडिक पीएच में ही पॉलीमराइज होते हैं. तो डोंट गिव सुक्राल्फेट विद अलोंग विद द एंटासिड्स. एंटासिड्स जो देंगे तो पीएच बढ़ जाएगा, पीएच बढ़ जाएगा तो पॉलीमराइजेशन नहीं होगा, तो सुक्राल्फेट विल नॉट वर्क. ओके. द सेकंड एजेंट वाज कोलाइडल बिस्मथ सब्सट्रेट. इसकी टॉक्सिसिटी भी होती है कोलाइडल बिस्मथ सब्सट्रेट की, एंड इट इज आल्सो अ ड्रग फॉर द एच पायलोरी आल्सो. एडवर्स इफेक्ट क्या है इसका? ब्लैकनिंग ऑफ टंग एंड बिस्मथ टॉक्सिसिटी. डिस्कस बिस्मथ टॉक्सिसिटी होती है एंड ब्लैकनिंग ऑफ टंग. Now coming to the finally anti-H pylori. Helicobacter pylori, this the structure of Helicobacter pylori itself can cause the secretion hyperacidity, and it can cause the peptic ulcer. So sometime there you are giving the antacid and all PPIs, H2 blockers, you are all giving all everything, but then also the patient is not relieved. After some time again this appears, this hyperacidity came back. The one reason can be because of the infection with the Helicobacter pylori. And if there is a Helicobacter pylori infection, you have to treat with this infection with the antibiotics only. So Helicobacter pylori is a gram-negative bacillus. It's a high urease activity. It produces the ammonia, which maintains a neutral pH. It can cause the chronic gastritis, dyspepsia, peptic ulcer. So all these things can be there. And the antimicrobial agents which are approved for the H. pylori is the amoxicillin, clarithromycin, tetracycline, metronidazole. So I have the mnemonic of that also. You can remember the regime part. So very easily, amoxicillin, clarithromycin, tetracycline, metronidazole. These are the antibiotics. Amoxicillin, aminopenicillin, clarithromycin, and tetracycline. So these are the protein synthesis inhibitors, and metronidazole. These so antimicrobial agents. These are having the effective for the H. pylori, Helicobacter pylori. So two regimes are very important. Two regimes very important here for the Helicobacter pylori. One is the triple drug regime and one is the quadruple regime. Triple drug regime, you remember with the, please remember with the mnemonic CAP. C is for two antibiotics, clarithromycin. A is for amoxicillin, and P is for PPI. PPI, any PPI, pantoprazole, lansoprazole. So please notice this one. There is two antibiotics and one PPI. So there's a combination of three drugs, two antibiotic plus one PPI. Okay. So clarithromycin, amoxicillin, and lansoprazole. Please remember the dose also, because this is important. 500 milligram, 1000, 500 milligram, 30 milligram, and this is given twice daily for 14 days. Clear? Now the second one is the quadruple regime. Quadruple regime is again will have the PPI, two antibiotics, one PPI will be there, two antibiotic tetracycline metronidazole, one PPI lansoprazole, and one bismuth substrate will be added. And यहाँ पे dose लिखी हुई है BD QID QID QID. So you remember these the dose also for 14 days. So this is also given for 14 days, and that also the triple drug and quadruple both drugs regime are given for 14 days only. Clear? So remember this regime with the CAP: clarithromycin, amoxicillin, and PPIs. At least this you will remember. And other antibiotics which you can use is tetracycline, metronidazole also. Okay, done. Okay, now just MCQs for you. So now please answer the MCQs. All of the following agents are avoided with sucralfate for the treatment of peptic ulcer except. कौन सी एजेंट हम नहीं सभी एजेंट अवॉइड करते हैं फॉर द ट्रीटमेंट ऑफ पेप्टिक अल्सर एक्सेप्ट, मतलब कौन सी एजेंट हम दे सकते हैं विद द सुक्रालफेट? रेंटिडीन, कैन वी गिव रेंटिडीन? ओमिप्राजोल, कैन वी गिव ओमिप्राजोल? मिसोप्रोस्टॉल, एल्यूमिनियम ट्राइसिलिकेट. तो व्हाट विल बी द आंसर ऑफ दिस? Misoprostol. Why? Because all ranitidine, omeprazole, aluminum trisilicate, all this will decrease the acid, will decrease the pH, will increase the pH of the stomach. So it will inhibit the action of sucralfate. Misoprostol will not inhibit the action of sucralfate. So that's why, because sucralfate was requiring the low pH to act, was requiring the acidic pH to polymerize. We have seen that. Okay. The second, mark the wrong match about the drug for peptic ulcer and its mechanism. Ranitidine, yes, it's H2 blocker. I think yes, it's H2 blocker. Lansoprazole is a proton pump blocker. Yes. Misoprostol, EP3 receptor agonist. We have seen misoprostol acting on through EP3 receptors. Sucralfate is H plus K plus. H plus K plus. What is H plus K plus ATPase? It is again the proton pump. Name of the proton pump only. Sucralfate is not H plus K plus ATPase. So what is sucralfate? Sucralfate is an ulcer protective drug. Okay, very good. Which of the following anti-H. pylori triple drug regime is correct? 2 antimicrobial plus 1 acid, 1 antimicrobial plus 2 acid, 1 antimicrobial plus ulcer protective plus PPI, 1 antimicrobial plus ulcer protective plus H2 blockers. The answer is, what was the mnemonic of that regime? CAP. CAP was clarithromycin, amoxicillin, and PPI. Clarithromycin and amoxicillin was antibiotic, and 1 PPI. So answer is this: 2 antimicrobials plus 1 acid reducing drugs. Okay. Thank you very much for paying the attention.